Hello doctors, good day. Welcome to my channel Dentist Data Sir. Today we are discussing about a most challenging clinical scenario. It's the management of immature non-vital permanent tooth. Really it's a miraculous regeneration journey. So therefore we need to have a deeper level of understanding of what are the things going to happen in this regeneration or recreation process. So without wasting the time, let's dive in directly into the topic. Before diving into the actual topic, let's start with an overview of how to manage an immature permanent tooth. So, if the immature permanent tooth is vital, then there is a histological process called apexogenesis where a complete root formation occurs. So, which can be accompanied with indirect pulp capping or direct pulp capping or partial pulpotomy or full pulpotomy. If the immature tooth has become non vital, then we are left with two options, that is, apexification or regenerative endodontic procedure, also called revascularization. The outcome of these three processes, apexogenesis, apexification, or revascularization, is the result of interaction between the dental materials like calcium hydroxide, MTA, or biodentin like materials with the differentiated or undifferentiated cells of the pulpodental complex. Apexification, that is root enclosure. By definition, apexification is defined as a method of inducing calcified barrier in a root with an open apex or the continued apical development of an incompletely formed root in the teeth with necrotic pulp. That is, by the process of apexification, either a calcified barrier at the open apex is formed or there are chances of a continued apical development occurs in incompletely formed root in the case of a teeth with necrotic pulp. So, what are the indications? The procedure is carried out in non-vital permanent tooth with incompletely formed root. The materials used are calcium hydroxide, MTA, biodentin, or similar materials. The objectives of apexification includes the process should induce a root end closure or apical barrier formation which is confirmed clinically and radiographically, along with the resolution of the clinical signs and symptoms like sensitivity, pain, or swelling. And during or following the therapy, there should not be any radiographic evidence of external root resorption, lateral root pathosis, root fracture, or breakdown of the periradicular supporting tissues. And the treatment should not interrupt the eruption of the tooth and also the formation of alveolus in conjunction with the adjacent teeth. This slide shows the possible outcomes of the calcium hydroxide apexification. So you can see there is possibility of formation of a newly formed apex, or there are chances of formation of calcific bridge which is up to the level of the root apex, or formation of calcific bridge which is short of the root apex. So these are the possible outcomes of the calcium hydroxide apexification process. Now coming to the disadvantages of calcium hydroxide apexification process, as just now we have discussed the possible outcomes of the calcium hydroxide apexification, that is, a root end may be formed or a calcific bridge can be formed, but a partial calcific bridge can also be formed, leading to leakage and persistence of the periapical inflammation. This process is a very lengthy process. It requires 12 to 24 months of time period, which requires a change of the dressing every 3 months to 6 to 8 months, or sometimes doesn't require. As the CH apexification process is very lengthy process, the root dentin is continuously exposed to the calcium hydroxide, and this long term exposure causes reduction in the fracture resistance of the root dentin, leading it to causing the cervical fractures. And another most important drawback of the apexification process is This apexification process does not induce the root length development or root width development. So it just can close the apex, but a physiological root development is not possible with the calcium hydroxide apexification or any apexification process. In order to overcome these drawbacks, an alternative to the calcium hydroxide apexification process is proposed, that is, using MTA as an apical plug. So, what are the advantages of apical plug with MTA are? It requires fewer appointments to complete the treatment with reduced need for the patient follow up, and the results, that is the apical barrier formation, is more predictable. And the disadvantages of MTA apexification process are similar to the calcium hydroxide therapy, that is, it just forms or closes the apex with a calcific barrier. It doesn't induce the root development, and in addition, it causes staining of the teeth. MTA causes staining of the teeth. So by this time, we would have known that what is the role of pulp vitality in our lives and to what extent we have to go to protect its vitality. Regenerative endodontic procedure or revascularization. A regenerative endodontic procedure is defined as a biological based procedure which is designed to physiologically replace the damaged tooth structure, including the dentin and the root structures, as well as the pulp dentin complex. The indications are: this procedure is indicated for non vital permanent teeth with incompletely formed roots. And what are the goals of these procedures? The primary goal is to eliminate the symptoms and to produce the evidence of bony healing. This is the primary goal. And the secondary goal, which is desirable but perhaps not essential, is to increase the root wall thickness and or to increase the root length. The tertiary goal is to form a more organized vital pulp tissue, that is, bringing back the vitality of the pulp. As the name implies, many clinicians think that the primary goal is to bring back the vitality of the pulp, but it is not. The primary goal is to eliminate the symptoms and to produce the evidence of bony healing. And after achieving this goal only, the rest of the things are taken into consideration. That is, the root length increase, the root thickness increase, and then uh, the vitality of the pulp achievement is considered. And the possible adverse effects are: as we are using MTA, there will be staining of the crown or root, and there can be pain or infection if the symptoms are not subsided. And final adverse effect is no response to the treatment. That means the pulp remains non vital even after this revascularization procedure. If we observe closely the procedure of regenerative endodontics, it's similar to conventional endodontics. I mean, the conventional root canal treatment, where we are removing the necrosed pulp and disinfecting the canals. But the only difference is, in the conventional root canal treatment, we obturate with a gutta percha. But here, in the case of regenerative endodontics, we use host's own vital tissue to fill the root canals and allows the stem cells to differentiate and do its regenerative work. And the objectives of the treatment: there should not be any post treatment clinical signs or symptoms like sensitivity, pain, swelling, resorption, root pathosis, including root fractures, and the tooth should continue to erupt along with the alveolus in conjunction with the adjacent teeth, and the procedure should increase the root wall thickness, root length, and everything should be evident by radiographic examination. Root length and all the changes should be clinically and radiographically evident. The key components of the procedure are the stem cells, the growth factors, and the favorable patient age, 8 to 18 years, bacteria free canals, bleeding from the apical tissues, formation of a blood clot in the root canal, sealing the cervical area with a biocompatible material, and a sound coronal seal. As we discussed earlier, the difference between the regenerative endodontic procedure and the conventional root canal therapy is in the regenerative endodontic therapy, we use host own vital tissue to fill the canals, which is known as a scaffold. The scaffold is a physical structure upon which the stem cells can organize, arrange themselves, differentiate, and develop. So the scaffold naturally it can be a blood clot or synthetic scaffold can also be used like autologous platelet rich plasma or hydrogels which are a three-dimensional hydrophilic polymer. And now coming to the actual procedure of regeneration treatment. So the procedure is similar to the conventional root canal treatment, but the more emphasis is on irrigation, disinfection of the root canal, as we are proceeding with the minimal or no filing technique. So once the access is gained and pulp is extirpated, and the root canal system is irrigated with the copious amounts of 2.5% sodium hypochlorite, and then by using lure lock syringes because it's an open apex and should be careful not to damage the stem cells present apically. So after this a meticulous irrigation with a 5 ml sterile saline solution is also done. Later, the canal is filled with the low concentration of calcium hydroxide, which acts as a disinfectant and also pulp remnant removal. Or low concentrations of triple antibiotic paste, as we discussed earlier, is a mixture of 1 is to 1 is to 1 ciprofloxacin, metronidazole, and minocycline to a final concentration of zero point 0.1 to 1 milligram per ml. So this triple antibiotic paste is associated with the tooth discoloration. So we may go with a double antibiotic paste or replacing this minocycline with either clindamycin, amoxicillin, or cefaclor. So if triple antibiotic paste is used, ensure that it remains below the CEJ to minimize the crown staining, and later sealing the coronal part with 3 to 4 mm of the temporary restorative material like cavit, IRM, glass ionomer, or any other temporary material, and the patient is recalled after 1 to 4 weeks. During second appointment, that is 1 to 4 weeks after the first visit, we have to assess the response of the initial treatment. So whether there are any signs or symptoms of persistent infection, or do we need to consider additional treatment time with antimicrobials or alternative antimicrobial therapy. So we have to give an anesthesia with a 3% mepivacaine without vasoconstrictor and isolation of the tooth, and then copious irrigation with the 20 ml of 17% EDTA and drying with the paper points. Once the canal disinfection procedure is finished, now we have to consider filling of the root canal treatment with the patient's own vital tissue. For this, we need to create bleeding into the canal system by over instrumenting, either with the endophile or endo explorer, 2 mm past the apical foramen, with a goal of having the entire canal filled with the blood to the level of the CEJ. Alternatively, we can use platelet rich plasma, platelet rich fibrin, or autologous fibrin matrices. So, we have to stop the bleeding at the level of 3 to 4 mm below the CEJ level, so that we can give a 3 to 4 mm of the temporary restorative material. The blood clot is covered with a resorbable matrix such as cola plug, cola coat, cola tape, and over that a white MTA as a capping material, and over that 3 to 4 mm layer of glass ionomer cement. The discoloration rejection effect of MTA can be managed with other tricalcium silicate cements like biodentin. During the follow-up, clinical and radiographic evaluation should be done for the symptoms, signs and symptoms, and resolution of apical radiolucency, increase in the width of the root walls and root length, and should check for the positive pulp vitality response. So, by this, the management of non vital immature permanent tooth lecture comes to end. Hope I would have covered all the necessary information. So, please like, share, and subscribe our channel for more lectures. And please comment what are the topics you want me to cover further. Thank you. Thank you so much.